All right, guys, welcome again. We're back again, Nerva Plus, with myself, Richard, can present to you guys on tendinitis. So thanks to everyone that's jumped in today. So on tendinitis, we wanted to cover a few things. It's a very common complaint. A lot of people have a very common diagnosis. And we wanted to help you guys all understand a little bit more about what it is, the causes, the risk factors, the things that it is, and pretty much how you can take yourself from having a tendon problem, because we have them all around the body, from varying different sports, and how to move towards recovering from that tendon problem. And obviously, we have our Q&A at the end. So that's what's ahead. Let's get into it. So basically, we're going to start with the definition really quickly. A tendinitis is basically just an inflammatory condition caused by repetitive overuse, poor load management, or a sudden increase in activity and load through a particular tendon. So we've got a couple there that are really common. So we've got your Achilles, which is down in your heel. We've got your patellar tendon in your knee, rotator cuff, which is in the shoulder, or golfers and tennis elbow, which is inside and outside of the forearm there. So what that definition basically means is that tendinitis occurs when you have irritation of a tendon, which connects the muscle to the bone. And that irritation occurs usually from two reasons. Either the amount of things that you are doing is higher, so the load of the tendon is currently higher than what it's used to, and that quick change or quick increase obviously irritates the tendon, or you have a deconditioning effect that occurs where the tendon is now beginning to become not as tolerant to load as whatever your daily activities are, and that can commonly happen through lack of movement, lack of training, going off track with a couple of movements and things like that. So basically it happens where there's more load than at the particular structure in the body can handle, and then we end up with this thing that we call tendinitis. On an aside, inflammatory condition, there is a lot of debate out there whether tendinitis is actually an inflammatory condition. One of the questions we have a little bit later, which we'll just answer right now, is do we use itis or opathy? Should we use itis or opathy when referring to tendon pain? That has got a lot of research out there about, and they're still figuring it out. Currently, the researchers are debating whether it is an inflammatory condition or not. But at the end of the day, for most of us in the general population and a lot of clinicians, all we need to know is that there is irritation through the tendon, and whether there's an inflammatory process happening there or not, it doesn't matter. Even if it's not inflammatory, you can still use things like ice, and that can sometimes help as well. So basically, tendon can't handle the load or the amount of load that you're asking it to do, and that over a long period of time is what usually leads to tendinitis. So yeah, these are obviously some pictures here, guys. We've got, the Achilles tendon. So as you can see in each of the pictures here, the white section or the red that is within the white. So the white is the actual tendon itself. And as you can see, it comes from the muscle. So the red part comes down to white and then inserts into this opaque yellow sort of part, which is the bone. So the job of a tendon is actually to transfer force from the muscle belly. So all of these are muscle bellies, quad, rotator cuffs through here, elbow and forearm extensors up there. So its job is to transfer the force from the muscle belly down into the tendon, which then obviously it acts on the bone, and that's what actually helps us to move the joint. By using these, we actually allow the body to become really springy, and the tendon helps us to store a lot of force and then release that in quite an elastic way. So it has a really important job in movement, and helping us to honestly be bouncy in our movements. So we covered a little bit before common causes of tendinitis, but basically you've got them here. Either what you are doing here is more than what it's been doing in the past. So this is where we've got increases in training volume or poor load management. This will be people that are doing not a couch to 5K, but they'll be doing a couch to a half marathon. And they'll be going through those increases really quick. Instead of starting with a really easy, gentle progression, building their aerobic base by, doing numerous amounts of runs a week, maybe 1 or 2, 3, 4Ks, and then slowly building 5, 7, and then 10. They'll jump straight in from 0 to 5 or 0 to 7Ks and just be pushing really hard. And that obviously doesn't allow time for the body to adapt to the loads that come about from running. So that's this here. Or we've got poor load management, where we may have someone that is currently a runner and they may be running, let's just say, 5Ks on average every week, but all of a sudden they're like, oh, I've signed up for the Sydney Marathon. I need to go and, I need to start training, and they'll do their 5K run that they were doing once a week, all of a sudden they'll up that to 3 to 4 times a week. And so basically that's just an increase very rapidly in what they're doing. And that's obviously leading to some tendon issues here. The other thing here is, which is also a little bit part through here, which is basically you're not using the body well enough and you're not taking care of it well enough and moving it. And what's happening is the body is then becoming deconditioned, which means that there is a relative lack of load or lack of capacity through that tendon. And then what you are doing through life, be it maybe you're a manual laborer or you have a repetitive job or even just walking around, you can start to get some of these tendon issues. You can also get, these things here where we're looking at bad shoes, cheap tennis rackets, not high quality golf clubs, things like that don't absorb the shock and vibration when you're playing the sports. We've also got things here where you're not flexible and mobile enough, so you're not spending enough time opening up through the body, stretching, doing some of that recovery stuff, or you have really poor movement patterns. But basically, we've got those two camps: the not moving enough or moving too much too quick.
And then tendonitis is your accumulation effect.
And then, yeah, you're right, Lockie. Tendonitis is your accumulation effect. And it usually does take a couple of weeks for it to kick in before you realize you have an issue. So that tendonitis, that accumulation effect can be happening in the background where there is no pain, but you still have a problem occurring. So this here is just a little bit of a diagram here, guys. As you can see here, this is obviously the muscle belly, and this is the tendon as a whole. And all they've gone and done is just dissected it down layer by layer by layer. This is a little bit more detail than probably required right now. But the thing you want to really be paying attention to is this section here and this section here. So this is just bunches of fibroblasts, which are grouped together to form a bigger structure. And then inside of each of these little white things, you've got these lots of little dots, which are, again, more fibers that are all connected, almost like a piece of rope. Now, what we have looking here through a healthy tendon is basically all of these fibers of collagen fibrils are actually pointing in the same direction. They're all uniform. They're like a pack of spaghetti in the packet. They're all pointing in the same direction. They're sitting next to each other. They're still uniform. They're still straight. They're still flat. What happens when you start loading this more than it can handle, or it's not able to keep up with what you're asking it to do, is that you start to get a little bit of irritation through some of these. And then all of a sudden, these nicely laid out pieces of spaghetti don't sit uniform anymore, but then start to point in slightly different directions, which actually decreases that tolerance of that tendon for a specific load direction. So it might be up and down. All of a sudden, the fibers don't point up and down anymore. They're starting to go a little bit of oblique angles and things like that, which means the ability of that tendon to go up and down and absorb those up and down forces becomes reduced. And that's what we're looking at over here on this side. So this is where all of a sudden these fibers are no longer pointing in the same direction, which massively reduces how much load that tendon can take. And then when you expose that, be it by your Achilles tendon by running around, that's when we start getting this tendonitis or tendinopathy kind of effect through here. So there is structural changes that occur with these tendon problems. An easy way to think about it, or a really common way to think about it, this is from Jill Cook. She's one of the leading tendon researchers currently, is that you've got a donut and there's a hole in the donut. The problem with tendons is that it usually occurs in the center first rather than on this outside part here. So the problem is usually the hole of the donut, not the donut itself, which is why it can take a long time before we notice any symptoms, because this process here, these deorganization of the collagen fibers is actually occurring right in the middle, not on the outer portions. So we won't always notice an effect until we're a couple of weeks in. And then from there, what will happen is a lot of our modalities that we use with tendon problems actually only affect this outside portion. It's hard to get into the middle. So then the effect of the treatment and the reloading protocols that you need to help with the tendon actually take quite a few weeks as well, because we're looking at this center portion of it. We're not looking at the outside. They often say in Jill Cook's research to treat the hole, not the donut. All right, so what does a tendon feel like? How do we know we have what does tendonitis feel like? How do we know we have tendonitis? Basically, we're looking at pain with movement, over the tendon itself. So if we're looking at the Achilles tendon here, you will have tenderness over that. Usually if you poke it or squish it or press it, there's often a period of stiffness that's worse after you haven't moved for a period of time. So if first thing in the morning because we've been asleep, or if you've been sitting down for a period of time, 4 to 6 hours at work, and then you got to get up, you will get this stiffness, which can also sometimes be painful. Almost like there's someone holding onto your calf or whatever area the tendon's in. You can get swelling that's usually hard to see because around tendons themselves, there is not a lot of other structures usually, and so that swelling can actually start to hide away into little spaces through the body. But you can sometimes, if it's really bad, get swelling over the top that you can see from the outside. So that's how we know if we're starting to get tendon problems, what it feels like, and things like that. So basically, if you have tendonitis and it has been a problem, it usually is a problem for quite a long time. They're pretty nasty in terms of they're very stubborn and persistent. So sometimes people can have periods of tendonitis where they'll have an initial spike in pain. It will then start to lower and dip once they stop doing the thing that's aggravating, so the aggravating activity, and then they resume that again, and then from there it spikes back up, and they go through this cycle of up, down, up, down, up, down, but it usually goes in an upward fashion like that. It does take a while for that to occur. So if you do have pain through your tendon, it's nothing to stress about. But that also, because that tendinitis or tendinopathy effect, accumulation effect takes time to occur, it does also sometimes take time for it to come back down. That's why really good management of a tendon over the long term, beyond just the painful part, is critical if you're wanting to make sure that your tendon problems are being managed well. And that's where you would definitely be looking to engage with some kind of healthcare professional. And if you are doing some kind of activity, say, for example, you're trying to run for a marathon, or you're training for a bodybuilding comp, or you're looking at a powerlifting comp, you are wanting to engage with someone that can help you to manage your load and calculate how much volume you should be doing, running, lifting, etc. throughout the week, and then on a greater cycle, over a monthly cycle, over a block, over 3 months, so on and so forth. So yeah, tendons can be a little bit tricky, and they do usually require a little bit of input from some kind of professionals. So basically, the keys to recovery: tendon loading. Tendon loading is the most important thing when you are dealing with tendon problems. They don't respond to rest. They stop hurting when you're resting them, but then usually as soon as you start doing the thing again, it comes back, like I was saying. So stopping what you're doing or completely resting usually doesn't help us, at least to poorer outcomes long term, because when you stop doing the training, the tendon and the muscle will then continue to decondition, and you might have stopped for a period of 4 to 6 weeks. Trying to then get back into that threshold is now lower than it was before. So this is why we need to figure out how to load the tendons, continue to load them in a certain way, but just making sure it's just enough so we're not tipping it over the edge and aggravating it further. So this is where progressive loading is crucial, and working with someone that can help you with that progressive loading is the most important thing with tendons. Usually in terms of tendon rehab, we're looking at isometric hold. So where you're coming down, you're holding that position through that tendon for a period of time. We're looking at slow, heavy resistance training. So we're coming down at nice eccentric, slow eccentrics down through a movement, and just using that tempo of the movement to help load that tendon up. And then eventually progressing towards plyometric and functional loading. But these two are usually the keys early on in the beginning. And like I was saying, guys, that the load should be just right to stimulate healing and recovery, because that is what tendons need, but without excessively aggravating the issue itself. So that's where, like I said, you sometimes will need a professional to help guide you through that. But as a general rule, the rule of 3, 3 out of 10 pain or below is generally acceptable with tendons. It means that you can feel some minor symptoms up to a 3 out of 10. But if you're progressing beyond that, you're starting to find out that the tendon will then flare up the next day or later on that after the session, after you cool down. You usually get an increase in symptoms after that. So basically, in summary, guys, tendon loading is the key here. That is what you want to be doing to making sure that you are progressing each week through the tendon problem and not going backwards with it.
Same with all health and fitness, right? Slow progress, boring progress is good progress.
100%. Yeah, yeah. Slow progress, boring progress is good progress. Definitely. You'll often find though with muscular adaptation, bone adaptation, and other tissues throughout the body, that slow boring progress does actually occur faster than tendons, and that is literally because the tendon itself, if you're having a look here, I can't really zoom in, but there isn't a lot of red. Whoopsies. There isn't a lot of red through the tendon. The tendons are usually colored white, not just on diagrams, but in real life. They're usually an opaque white color. And the reason by that is because they don't actually have a lot of capillaries or blood vessels into them. So when a tendon becomes injured or damaged, because there's no blood vessels infiltrating that tendon, there is not really a way for it to quickly get nutrients and healing factors and oxygen into the tissue. So all of it gets bathed in this nutrient factors outside of the tendon. And the only way you can get in is by a process of osmosis or diffusion. So it actually requires the tendon to pump like this. And by pumping on that, it can actually draw in some of that good stuff to actually help it to heal. When we're starting to get this through here, see how they've colored this tendon orange or reddy in color. See this phrase here. I don't know if you guys can see that. It's a little bit little, but it basically says capillary ingrowth. So when we have a disorganized or injured tendon, we will typically get capillaries growing into the tendon, which will then bring more blood, but it usually is also associated with mechanosensitivity and pain sensitivity through that tendon. So it's not actually something we want, because there isn't a lot of nerve endings in the tendon. There isn't a lot of blood flow through the tendon itself. And it requires movement and pumping of muscles and tissues to actually draw healthy, good stuff into the tendon. So yeah, it actually takes longer because of that lack of blood flow. So that boring, slow progress, particularly with tendons, can happen over a really, really long period of time. And this here, guys, this is straight out of Jill Cook's research, I believe. But basically, it just is a diagram as to how a normal tendon can then move towards reactive disrepair and degenerative. So basically what they're saying here, guys, this is a normal tendon. There is no pain associated with this. We get an issue, which is excessive loading. It then goes to what we call a reactive tendon. That's where you'll get pain right here on my elbow. Boom, I can feel it. You poke it, it hurts. I grip, do pull-ups or chin-ups or bicep curls or something like that. Hanging from the rig, bench press, I can feel it. It's tender and painful. That's what we call a reactive tendon. If we're able to change our load and have some rehabilitation movements through there, we can bring that back to a normal tendon. But if we don't, it then goes to what we would call a disrepair stage. If we continue to load that, so if you're continuing to do multiples of pull-ups and that tennis elbow is still hurting, it would go to a disrepair stage, which is obviously associated with more collagen, fibril disorganization, more capillary ingrowth, more issues basically. Then obviously we're going towards excessive load. Again, that's where we're starting to talk about the degenerative stage. Now, it can reverse from each stage back, but you can't skip from a degenerative to a normal tendon. You have to go back through these progressive points in order for the tendon to, I suppose, what we call normal and healthy again. However, usually what I find with just clinical experience is that these two here, reactive and disrepair stage, if we're able to intervene, we have a pretty good chance that we can get this tendon back to what we would want, and it wouldn't have as much of an issue. Once we get to this degenerative stage, we can be talking a significantly longer period of time. And clinically, I just find people don't have the time or the want to invest into getting it all the way back to a normal tendon. They're usually happy to leave it somewhere around here where it's sort of an issue, but it's not as bad of an issue. But obviously always encouraging people to...
Can I just jump in on that as well? I feel like if we see people get to the degenerative stage, it's very hard to work their way back because they've actually worked their way to the degenerative stage to begin with. Degenerative stage to begin with.
Yeah.
Is that fair?
Yeah, 100%. They've worked their way all the way through there. They've ignored it. They've worked around it. They've just pushed through it. They've continued to do the thing. And so it just takes that much longer before we're moving back towards all of this stuff. So, for example, like there's one patient that I've had. She was about 85 at that point. She had persistent lateral hip pain, so hip pain on the side through her glute med. I think we talked about glute med area in one of the previous webinars. But she had this pain for 15, 20 years. She used to be a nurse. Eventually we got a sketch. She'd seen everybody for it on the beaches, and then eventually got a scan. We found her glute tendon was degenerative, and in terms of getting her back, we were looking at 3 years if it even went back. So we got an improvement in her symptoms. We managed to get her somewhere in this stage, maybe middle through here, somewhere a little bit more towards disrepair. Massive increase in symptoms. She could walk around, but in terms of getting all the way back to a normal tendon with her age, with her current or pre-existing strength levels, with her compliance in terms of actually wanting to do things about it, and just her general willingness to accept the fact that this will be what it is. I've always had it. You don't understand. We never were able to quite. So we've gone out for about 2 or 3 years, and definitely helped. But eventually, it wasn't enough.
So, team, once we experience any pain, we want to see a professional. Any pain that's not muscular, of the good kind.
Yeah, 100%. 100%. And I think we even talked about this before. Like, sometimes seeing people preventatively or preemptively is not a bad thing. To get a niggle fixed up, get a little bit of treatment. Sometimes that's all it needs. Hey, I feel this a little bit. Can you just alter your chat to Lockie or chat to your coach, alter your program slightly, 2-3 weeks? Not a problem.
Yeah, even if it's just a slight cue.
Yeah, 100%. So, guys, that's just a diagram so you can conceptualize how long it would take for one to then move through these stages, but then obviously back through these stages again. It takes time. With tendons, you have to be patient. And as always, it is important that we're able to keep on training. So you don't want to you don't want to stop training, like I said, because that will obviously lead to long-term poor outcomes. You do want to be looking at modifying your exercises, not stopping them. So swapping high impact for lower impact or lower load options, reducing the explosivity of movements, and adjusting your range of motion. So, for example, that might look like going from running hill sprints, and we're just modifying it to continue for you doing some flat runs, minimal gradient, really just tempo paced runs. Or even further, we might be looking at getting you in the pool or on the bike so that we're taking that slapping foot on the ground, high impact for a lower load whilst maintaining your cardiovascular and aerobic fitness. We've got that here. Okay, maintain fitness with no aggravating activities, swapping running for swimming. And then obviously if we're dealing with a lifter or we're dealing with someone that is more limb specific, you can continue to maintain your strength by training obviously the upper or the lower body or training other supporting structures. So for example, if you have tennis elbow, which is really, or even better, golfer's elbow, which is really common in people that are lifting weights, instead of you doing chin-ups, we might get you doing a lat pull down. Or instead of you doing a bicep curl, like a preacher bicep curl, we might get you doing reverse forearm curls, or even just a wide grip pull-up hold or something like that. There's many variations you can do. We are training just different areas of the body and just deloading or slightly reducing the load in that particular structure. And from there, we find some modifications. And from there, obviously, it allows you to keep training to maintain your strength as best as you can whilst you're going through your rehab and treatment protocol. And then obviously moving that tendon back from usually being a reactive tendon back towards a normal tendon so it's calm again. And then you would be engaging in some kind of long-term strengthening or plyometrics to improve the tendon beyond what it was before. Because an injury that you have doesn't always mean that you come back less than. You can often, if not usually, come back more than by doing some things that you just didn't have in your program or in your training before that. Learning a little bit more about how you move, learning a little bit more about how to program and things like that.
Hey, mate, are we past the point of referring anyone to cortisone injections?
No. So in terms of what you can do about it, you can use injection therapies for tendons. The only issue with certain injections, so cortisone or corticosteroid injections are probably one of the most common first-line things for a tendon. It depends really on the case. And the reason why is that if you have a high-level triathlete or someone that's very fit and very active and you send them off for a cortisone, there's a period of time where they shouldn't be doing that much load, 7 to 10 days at a minimum, usually. And you also shouldn't really be using the cortisone as a band-aid for you to keep training. That's where a lot of people get into trouble. So example, I've had a couple of cases now where we've had a triathlete, high-level triathlete come in. let's just say Achilles pain, they go and get a cortisone injection for it. The cortisone injection is actually corticosteroid, which is a type of anti-inflammatory, plus local anesthetic. And because you have local anesthetic, the pain is numbed and it's right in the tendon, so you can't feel anything. Then the cortisone kicks in, so no inflammatory reaction. So again, the pain is numbed, and they go right back to training. Within a couple of weeks, the issue is back. They've used it as a band-aid, and then all of a sudden the cortisone was wasted, because you don't want to be getting more than usually two cortisones in one particular area or one particular tendon within a calendar year. And the only reason for that is because the cortisone will actually weaken the structures and degrade the tendon. So if someone's getting multiple cortisone injections and continuing to train through that, there is a chance that the tendon will actually rupture and snap. And then from there, we're looking at nothing else but surgical intervention, which will put you out for longer, and that becomes a real problem.
You answered that perfectly, because I feel like people would get the injection basically to just numb the joint and just get back to doing what they shouldn't be doing. So well done, man. That's answered perfectly.
Yeah, 100%. Thank you, Matt. The other injection therapy you can get, which is sometimes offered, is called PRP. That's platelet-rich plasma. That is basically where the doctor, is usually done by a sports doctor, will actually remove blood from you. They will spin the blood, centrifuge the blood, and remove just that platelet part of your own blood. Now, that platelet part is basically your healing factors. They will re-inject that back into the tendon or the injured place. And from there, hopefully it will help to kickstart that healing process a little bit more by just giving it a boost of the things that it needs to help with that. PRP, so cortisone, usually you're looking at one injection and you'll see some kind of result. I usually tell my patients that if they haven't seen a result after one, don't bother for a second. It's not going to do all that much. Or if they are going to get one, they can get another one, but no more than 2 in a calendar year. For PRP, you're usually looking at a minimum of 2 to 3 injections before you start seeing a result, and it can be quite expensive as you're going to a sports. So it's quite specialized. Not every sports doctor will do it. So it can be a little bit costly sometimes, but we have had some limited success with PRP as well. So those are the injection therapies you can kind of do that can help with tendons as well. So we're going to jump in there, Locke?
No, that's okay. That's you nailed both, mate. That's really good.
Perfect. All right. So do I need to see someone? So as you've kind of guessed throughout this whole webinar, yes, usually you do. You can manage tendons on your own with enough education and knowledge, but it is difficult and it's not easy. So yeah, usually it's best to see somebody. Now, who that person is really depends on how bad the tendon is and whom you have in your health and fitness team. But usually what I would be recommending is you're seeking the advice of a health professional. Usually it should be a health professional engaged in rehab and strength and conditioning. So you're looking at a sports chiropractor, you're looking at a physiotherapist, you're looking at someone that can help you to diagnose the tendon problem and then begin some of that strength conditioning rehab sort of piece of the puzzle, seeing whether that helps you to work load management rehab protocols, seeing whether that helps to manage the tendon. And if that's still not working, then they would be looking to escalate that on to a sports doctor for either a cortisone or PRP injection therapies. So yes, usually I would recommend somebody sees somebody. It can be done via telehealth, as I understand sometimes people have tendon problems and they can't always get into someone. You don't always need to treat a tendon problem. It can be really helpful when we're dealing with tendonitis or tendinopathy. But the key here is actually load management and strengthening rehab protocols. That's the key there. The treatment in cases like this is usually like sprinkles on top of the cake. It can help, it can move you in the right direction, it can aid, it can be done for pain management, pain modulation, but it's not the meat and potatoes, it's the salt and pepper. Yeah. So find someone in your health and fitness team. If you don't already have someone, then feel free to reach out to Lockie or myself, and we can obviously recommend if you're not locals. All right. So that is tendons, guys, in a nutshell. Basically, to sum it up, it's you have a tendon problem because you're either doing more than you should or you're not moving enough. The tendon problem, if you have it, can take a long time for it to develop and also a long time for it to repair. But the key here is long-term load management and rehab protocols over that long period of time. And that's what's going to help you move back towards through those different stages of degenerative, disrepair, reactive, and then back towards a normal tendon. I have a couple of questions here that I might just run through. Unless anyone else has any other questions, feel free to jump in. What have we got here? Because these were from the Instagram stories. Should we use itis or opathy when referring to tendon pain? I think we covered that one already. Fix my left knee. Thoughts on PRP for degenerative tendons? Okay, I think we've covered that as well. And then thoughts on rest for reactive tendons. Okay, so this one is from a practitioner, a physiotherapist. So he's obviously asking thoughts on moving the tendon from reactive to normal in terms of rest. This whole time we've been talking about load management and how to continue moving and continue training whilst just changing what you're doing slightly in terms of rest for the reactive tendons. So reactive tendons, we want load modification and rehab. When you're in the reactive stage, it's usually, as the name suggests, quite reactive. Rest is not something that you need to have, but it is a useful tool to put in place if the tendon is extremely reactive. So, for example, if someone is supraspinatus tendonitis and it's in reactive stage, they're going to have issues doing this kind of movement, lifting their arm up to the side. If that is so bad that even when they scratch the back of their head or they just rub their other shoulder or something like that and they're getting pain from there, normally rest is not something we would be recommending. But if they aren't even able to do those basic activities of daily living, we call them, so ADLs, so basic movements are required to look after ourselves throughout the day. Yes, you can sometimes use rest to help the reactive tendon start to settle. But from there, because it will hurt less, from there you would then begin loading, low-level loading and low-level rehab movements to then be able to get it. So rest will help for a particular period of time, a useful tool, but it's not a forever thing. You need to progress on from that once you've got the tendon to settle. And that's, again, where I said you're going to be needing someone to help guide you through this, because sometimes it can get a little bit murky and a little bit confusing in terms of where the tendon's at and what it's doing.
And like you said earlier, it's working your way through those stages slowly rather than going all the way to rest and then all the way to excessive nature when it comes to load as well.
Yeah, 100%. It sits somewhere in the middle, and that can sometimes be the difficult thing for people. Where does the middle lie? It's almost like that Goldilocks. It's like not too little, not too much. It's got to be just right. And that just right varies a lot depending on the person, their fitness and training background, how big their training base is, and how strong they are, all these other different things. So it can get a little bit murky sometimes, but we're looking for Goldilocks load, really. Cool. All right. Any other questions from anyone out there?
Have you, I'll just jump in. Have you heard much about collagen and whether they're going to start injecting that, or what doses of collagen could actually be adequate? Or is that something still a bit taboo?
I haven't heard much about injecting collagen directly. I don't know whether injecting collagen directly into the tendon would help or not. I'm assuming there is some research out there talking about injecting stem cells, but I haven't heard much on injecting collagen directly. But like taking in collagen dietarily through either a supplement or through your diet can also help to support healthy tendons. But I haven't read much into whether that will help to reverse a tendon. We can only assume based on the fact that it will help to support a healthy tendon already. But in terms of fixing it and that being the sole thing, I would be unsure as to whether that's going to have the required result.
Cool. Well answered, mate. If someone has pain just to touch, at what point are they with the tendonitis? Is this severe if it's just a touch and they can feel it?
Like a light touch?
Yeah.
Usually if it's tends to touch and it's just, if it's an eyeball pressure and it's tends to touch, I would be wondering how bad that tendon is. But if we're putting a little bit of force into it, you're usually sitting somewhere, look at the very minimum, you're at the reactive stage. Once we start getting to degenerative tendons, they're not always tend to touch. Sometimes it doesn't hurt anymore when you poke it because the tendon is it's basically numb and, well, not dead, but not a lot of life in it anymore. But usually tendon to touch means that the tendon is still intact and that there are fibers there that you're stressing when you're poking it.
Okay.
Cool. All right, guys. So if anyone else has any questions, feel free to send them through into the group or DM us directly. As usually, you can find us on Instagram, Dr. Rich Can Fix, or Strive Sports and Health. We are located in Sydney, in Dural and in Norwest. But obviously, if you are looking for help with your tendon problems, we can obviously help with that. Like I said, telehealth can often be done. Load management is the key here. So feel free to reach out if you have any questions in particular. And if not, thank you very much again for investing in your wellness, and we'll hopefully see you all again in the next webinar.